intake. Several years ago, it was developed a dietary approach to stop hypertension, what is called the DASH diet. And you can see when you have a controlled diet and you implement the DASH diet, that you may obtain a decrease of almost 6 millimeters of mercury using this diet. But if you also, along with this diet, you lower the sodium intake of the population, you can even get more advantages to lower a little bit more the blood pressure. And with that, with this combination, we can go from around 134 to almost 122 millimeters of mercury in this population. So we can use the lifestyle modifications in order to control hypertension. We can use weight reduction. The recommended this go between 18.5 to under 25 body mass index, adopt the DASH eating plan, and also the dietary sodium reduction. What are we going to expect? A systolic blood pressure reduction between 5 to 20 millimeters of mercury over 10 kilograms of weight loss. To expect to 8 to 14 millimeters of mercury just adopting the DASH diet, and also to expect 2 to 8 millimeters of mercury decrease in systolic blood pressure along with that. These are the expectative that we may have to control hypertension. But not only from this point of view, if we can increase physical activity, making a regular aerobic physical activity over 30 minutes per day, most of the days of the week, and also to moderate the alcohol consumption, we can expect also a systolic blood pressure reduction from 4 to 9 millimeters of mercury, and also with alcohol from 2 to 8 millimeters of mercury using these modifications. About 3 days ago, Dr. Giuseppe Mancia, who is an international specialist in hypertension, was asked if he knew what were the ideal goals for systolic or diastolic blood pressure figures in the patient. The answer he gave is that we don't know yet. And why is that? Because there has been several studies that if you go very low with the antihypertensive treatment, you can cause a rise in myocardial infarction. That's called the J-shaped curve, something like that. But in any case, as long as we have been seeing in general populations, both in men and women, if we go less than 100/90, we can expect to avoid several cardiovascular diseases, several events. If we can go to 120/80, what has been considered the ideal figure for blood pressure, we can avoid more cardiovascular events. So we are still debating what are the numbers we need, but in any case, lowering blood pressure decreases cardiovascular disease. And if you see the distribution for systolic blood pressure, as long as we can reduce 2 millimeters of mercury, 3, 4, 5, look what we can gain in reduction in mortality, both in stroke or ischemic heart disease. We can reduce mortality by 6% just with 2 millimeters of mercury in systolic blood pressure. If we go to 5 millimeters of mercury in systolic blood pressure, we can reduce mortality by 14% in stroke, 9% in ischemic heart disease, and this goes for a very little decrease in the blood pressure and a very huge expectative in avoiding complications. So with exercise, we can decrease 5 to 10 millimeters of mercury. With weight reduction, 1 to 2 millimeters of mercury per kilogram of weight loss. The alcohol intake reduction, 1 millimeter of mercury per drink per day. The sodium intake reduction is we can expect 1 to 3 millimeters of mercury over 40 millimoles per day that we restrain from taking salt, and with the adoption of that diet, we can expect from 3 to 10 millimeters of mercury. But in a graphic form, you can expect with sodium reduction to a reduction of cardiovascular events of 31%, with weight reduction of 30%. When we use sodium reduction and weight reduction combined, we can expect a reduction of cardiovascular events almost to 53%. Alcohol calorie restriction, that is a restriction or reduction of 3 drinks per day, or a loose weight of 7.5 kilograms, to lower 4.8 in systolic, and with weight reduction 5.4 in millimeters of mercury, and also a similar change in diastolic pressure. The exercise accounts for similar reductions in blood pressure. So, based on this data, what have we done in Mexico in the last 3 years? We have several agreements signed by the health authority and industry in the processed food to eliminate trans fatty acids in order to lower the consumption of these elements and lower also the LDL cholesterol. We have signed also a reduced sodium in production, a reduced high energy carbohydrates in the production of this food. With the snack industry, who is one of the most important energy sources, especially for the young population, we have signaled a reduced salt in terminated product, and also modified advertising in order to promote a healthy diet among the population in Mexico. With the tobacco industry, we have laws that establishes a ban for consuming tobacco in closed public areas, and also we have modified advertising. It is banned from open public publicity and advertising, and also in the packs there is not only just the mention of the cost or the damage that the cigarette can cause, but also pictures in the packs illustrating what are the complications of smoking tobacco. We are implementing a relationship with the education authorities in order to increase the exercise in public schools, especially in the young. For elementary school, we have now that they make only 30 minutes a week of exercise in public education. We are trying to increase it at least 3 times this figure. And we have sent this also initiatives to the Congress. There has been an agreement between the restaurant industry in Mexico City. They do not do the salt shakers on the table anymore. If you want any more salt, you have to ask for it. And this has accounted for a reduction, at least in the consumption of salt in this industry, of about 25%. That seems to work for maybe to decrease the blood pressure in our population. So what we recommend right now is to lower the consumption of animal fat in order to lower LDL, to increase the use and consumption of unsaturated and polyunsaturated fat, namely fish, nuts, olive oil. Also, to lower the consumption of high energetic density food in order to lower our overweight and obesity problem, to exercise at least 30 minutes every 4 or 5 days a week, to avoid eating over 5 grams per day of salt, to avoid soft drinks with additional sugar, eat at least 3 portions of vegetables and 2 portions of fruit daily, and to consume antioxidants. Although they have not proved to avoid or to lower cardiovascular disease. In several studies, they tend to make the function of blood vessels a little bit more. What are our conclusions? About 4 of every 10 Mexican adults suffer from high blood pressure in Mexico. Hypertension affects both rich and poor. There are no social differences. Hypertension prevalence is up to 50% in some states in Mexico and is over 3% in every one of them. Hypertension is rising. If we compare the result from the surveillance, the enhanced 2000 and 2006 with our surveys that were done in 2000 and 2006, we can see the increment in 6 years of 36% in hypertension in women and almost 14% in men. During the same period in a comparable population, that's Mexican American in the United States, the hypertension decreased almost 14% in the United States. If the United States can do this change, I think we can do also in Mexico. The control is difficult, requires multidisciplinary action that involves health society along with the government action. Still, we have a big opportunities to interact with. Industry has a key role with modification in salt, sugar, and sodium content in products that may have enormous benefits. Adequate control of hypertension reduces cardiovascular mortality and morbidity. Lifestyle modification is a cheap and effective strategy for this. We have still some challenges to raise the awareness about this risk factor and the way they can be controlled in the adult population, as out of 10 Mexican adults have at least one risk factor. Continuous medical education for health professional and therapeutic options that have demonstrated real benefits and encourage adherence, that's one of our biggest problems, and involve all the social elements that may contribute to the development of intervention and increase the adherence to treatment options. Thank you very much.